round table called Patients and How to Have Access to Primary Care. I'm going to call upon Frédéric Chassagnol, Andrea Rapagliosi, Yves Lecam, and the moderator will be Yves Juillet. On paper, the process giving access to health products is based on an implacable logic. The industry perfects drugs or material and devices that the patient buys to care for himself, which enables the industry to pursue its research thanks to the profits made. But in reality, this virtuous circle doesn't always work. Now that almost all the major disorders have a drug or an implantable device, the area the industry can research into has reduced considerably. There are still weapons to find against cancer or genetic diseases or other conditions, but these personalized drugs are for a limited population. Not only do they cost a fortune, but are not devoid of risks for the patients. And which industrial is going to dare to go for that sort of thing? The result is it's the patient that pays. With drugs that are 20 years old, such as the drugs for hypertension or antibiotics. The issue of profitability is pivotal. But how can we set an acceptable ceiling? Of course, a final treatment against a disease such as hepatitis C is necessarily going to cost more than a chronic disease such as diabetes, which has to be taken for life. But all the levers to improve profitability are not always based on a consensus. And what justifies the fact that a drug should cost the same in Paris as in Brest or in the Drôme, where other consumer goods are very different? On the world scale, do we really want somebody in Dakar to pay as much for his drugs than in New York? It's because some pay a higher price, covering all the costs of the industry, that others can have access. Right, so good afternoon to you all. We're going to try and hold a very lively round table on the title, How Can the Patients Have Access to Healthcare Products? After this little video, which we've just seen. Some might think that everything's fine, that since we have the license and everything's transparent, but actually things are rather complicated on two aspects. First of all, we have the permanent concept of risk, which has a major influence in everything we do. And secondly, quite obviously, as we said this morning, the fact that the social accounts are in the red has a decision on all the decisions, has an impact on all the decisions taken, and where healthcare products are in the front line because that's where you can save the most money. So the issue that's raised, and I think that the video shows that fairly well, includes all those issues. And around this table today, we have Andrea Rapagliosi, who's Vice President of Sanofi Pasteur MSD, and Eric Chassagnol, who's in charge of access to the market, Eric Bazagnoc, who's Director of Economic Affairs. We were supposed to have Yann Lecam, who many of you know. He's the General Director of Eurodis, but he had a serious health problem in his family 2 days ago, and he had to unfortunately stay back. Thanks to Denise Silver, I met with Ivan Ekaye, who works for an association for renal disease and who accepted at the very last minute to participate in the round table. And I think that's very important because talking about these issues without having a patient at the table is not very effective. So we'll start by her because she explained to me that she had a sort of clinical case and that she's going to tell us about, which will launch the debate. And since, of course, she couldn't participate at the preparation of the round table, she can talk whenever she would like to. So Thank you once again for participating. Well, thank you very much. I didn't prepare anything, so I hope you'll be indulgent with me. But I'm going to talk about a difficulty that there is to get access to a drug to treat patients who have renal disease. There are only two treatments for renal disease. That's dialysis or a graft. And the graft is much more efficient than dialysis because it brings to the patient far more quality life and life expectancy. And it's also very good for the health system because it doesn't cost as much as dialysis. Dialysis costs about 80,000 euros per patient. The graft costs the same the first year, but the next and coming years, the costs decrease to 20,000 euros. So we're trying to make the grafts more accessible and make them last longer. If you have a graft, the likelihood is that you may reject it. And there are powerful drugs that have side effects that are available for them. And the mean survival is 14 years in France today if you've got a graft, which means that after 14 years, the patient loses his or her graft and has to either wait for a new graft or go back to dialysis. And this new drug is called accede. It's a drug that is a very specific one for several reasons. First of all, for the route of administration. You go to hospital once, and it's taken by the oral route, and it's a drug that has many advantages and drawbacks as well, because it doesn't suit all the patients. But for patients it does suit, which is a very special population, assessed to be about 2,500 patients in France. This drug is at least as efficient as the competing drugs, but it doesn't have the toxic effects of the others. Unfortunately, some of these drugs actually affect the kidneys. And in addition to that, it has an excellent cardiovascular tolerance profile, which means that it avoids most of the cardiovascular complications that these patients get today. Cardiovascular complications are the main cause of the death of transplant patients today. It costs a little more than the equivalents on the market today, but its advantages are going to have quite a big impact, because today, with 10 years follow-up, we have studies that have been published and showing that it improved renal function by 15 to 20% for the patients concerned. And of course, its tolerance profile means that it has less side effects. It's not accessible in France today. It's gone through the usual pathway. It was assessed by the Transparency Commission at HIS, and it was given level 4 in terms of improvement of services, which is low. And that means that we didn't get access to the market, but level 4 means that it can't be given total access. And since there aren't any other drugs on the list, it's impossible to have access to it. In December last year, we sent an open letter to the Minister of Health to say that for the patients, this was a drug that was very important. And today it is reimbursed in most of the countries in Europe and the United States. And the fact that we had no access to this drug, decided by the French authorities, meant that we were losing opportunities for the patients. It's used in France in a certain number of clinical trials today, but it's not reimbursed, so the hospitals don't cover it. But it has enabled some patients whose graft was stopping to make their grafts last longer, restoring renal function. Even a certain number of patients who went back to dialysis, it enabled them to get out of dialysis for a number of months or even years. So this is not just clinical data. We're talking about real life, and it's important for the patients to have access to this drug. It's not a drug that would suit everybody, but it's a loss of opportunity to not have it. So we contacted the ministry, and they decided to do a second assessment with 5 years of clinical data. It was assessed in May, and the Commission decided to not go back on its decision. It's still level 4, which is very debatable, taking into account the information I've just given you. The decision was based on criticisms of the methodology. And therefore, today, we're in a situation of deadlock because the situation hasn't changed, and the reasons that we don't have access to the drug are still the same. What we're told, what we hear in the ministry's department is that the cost is too high. We're in a patients' association, and there's going to have to be some sort of negotiation. Within the scope of this sort of product, the negotiation can only take place at CEPS. Once it's on the list, we'll be all right. But until it gets onto the list, we'll be in a deadlock situation. And France is now one of the rare countries in Europe that has prohibited access of this drug for patients. Well, I think that was a very interesting witness account, and it's on the basis of this, we're going to be able to launch the debate. First, I'd like to ask Frédéric Chassagnol, who looks after these issues at Roche, not only to react, but to tell me about the theory. As an industrialist, you work on access to the market. Tell me what difficulties you encounter on this type of issue. Good afternoon, everybody, to start with. Access to the market in France is something that is very strict. The framework is restrictive. After the evaluation of the benefit-risk ratio and the license to market, we discuss the reimbursement for the services rendered, and then we take a look at how we can improve the medical services rendered in comparison to the existing drugs. And all of this information is used to allow the Economic Committee to set a price. So we have a process that is extremely strict. But there are two things that come to mind. First of all, you have the length of time it takes to go through the process, which is very long, and which is a very important parameter for the patients to get access to innovative drugs. And another thing that is in the headlines today is the way these drugs are funded, because we have made quite a lot of progress over the last few years. And we've also turned towards biotherapies and targeted drugs since the 70s. And now we have diagnostic tools and treatments that enable us to treat the right patients with the right drugs. And today, the issue of how to fund these innovations is raised. And perhaps to push this to the very end, maybe we need a differentiated funding system. I was listening to our German colleague this morning. He was talking about two important words that made quite a lot of noise. That was outcome data. And then there's also the, I think he said another word. Oh, yes, it was we're going to do the revolution together. That was it. What was it? I wrote this down somewhere. No, it was important. It was on the way it was funded, but I'll come back to that later. Okay, so let's hand over to Andrea Rapagliosi. In Europe, we have a transparency directive that sets the duration and the HTA, the technological assessment. And very often on the European level, these things can be different. So give us a few comments. Well, first of all, thank you very much for your witness account, Ivani. Pardon my accent, I'm not a native French speaker. I've been to 5 different European countries, and I have children who were born in 3 different countries. One of them was born in Italian-speaking Switzerland, so it was very close to home, but I don't know much about products and treatments. So I don't really want to make a comment on that particular drug. But it's very difficult to accept the idea. And I'd like to tell you about something that happened to my children. I always say that Europe is wonderful, and I've worked quite a lot in Brussels, and we're going to be setting out a big European plan for health. But I think that we have to ring the alarm bells because we're going to have to pay a lot of attention to this system. If we're capable of explaining how these treatments should work in one country and not in others, it's probably our fault. And I think we've got to try and understand the countries we're working in, the legal environment and the medical environment in these countries. Two little things on the topics you've just raised. One is important, the linearity of the processes, because in France and in Europe, we've had the opportunity to participate in a study on the efficacy or effectiveness of the health models. And France played a big role in that and continues to play a role. But there was a discussion on the linearity of processes that work in Europe and cooperation with the HTA and the networking between the authorities on price, which are extremely effective. But there's not the same linearity in all the countries. And very often, things that are done upstream are repeated and repeated. So I think we need to customize the process on the basis of your environment and health budget, which is not necessarily the same as your neighbors. And a country that's participated in the common assessment in Europe has to develop the right culture too. Fortunately, we're just leaving the worst period of the crisis we had in 2007 to 2008. There are probably some countries in Europe that are more tired than others. And there may be a terrible black hole in the health budget, but we've got to give people a vision and try and balance prevention, diagnosis, treatment, and cure, and base our health policy on a pact. And above all, we've got to do this at a point in time where science has enabled us to move forward, because life expectancy was 65 years ago, whereas it's over 80 now. And that's not just a demographic challenge, because we're all consumers of public health. It's an issue that's very complex and that we've got to look in more closely. Right, so Eric, your first comment on this discussion. Yes, well, I think that the example, Ivan's example is a very interesting one, because we could spend the whole round table going into the details of it. And I think we have all the points we need, all the crucial points that are a threat to our system today, although it's well designed, that threaten the patient's access to drugs. Let's take the first subject. You said it took 2 years for the drug to be assessed. Well, that's a real topic. The European directive says that between the license and the publication in the official journal, the period is stipulated, and it's a lot shorter. And then you've got the reports of the activity of CES and HAS, plus the observatories. And in 5 years, the mean deadline before the drug is put on the market of 360 days. So we beat the record in 1993, 520 days. Another point is that there are probably issues of negotiation today. There are obviously the economic aspects and price. And another example that I'd like to give you through Ivani's example is the split of responsibility between each of the links in the chain of evaluation. I think that this probably is due to confusion in the system. The basics are very good, but this drug needs approval and it's well worth the community covering it. But several long months later, a purely administrative entity on the basis of arbitrary criteria is going to do the job that the transparency people have already done, and will be a third hurdle to the drug put on the market. And the hospital council is there just to see how we pay for it. And if the Commission has given its approval, and this is the second subject, I think that we need a sort of national board that says this drug has to be given to the patients at a cost determined by CEPS, and there shouldn't be any deadlock, there shouldn't be any blockade. But the problem is that due to various criteria and no funding available, even at its rightful cost, it won't be funded within the scope of the system. So there are two possible solutions. Either we could make sure that everybody does their own job throughout the whole chain of events, or we could invent a sort of supra-organization, something that works under the aegis of the Ministry of Health, to make sure that a drug that has a high SMR does get to the patient.
I'd just like to add that we tried to determine whether there were examples of drugs that had similar life histories, and we found several of these drugs for which the low ASMRs, they still deserved to access the patient. And the minister found solutions that were sort of complex solutions and very depending on the molecule, so that patients could indeed access the molecule. Despite this, this occurs fairly regularly, so it would tend to prove that the current system is not appropriate, because people had to find solutions to get around today's system. Yes, you're mentioning systems to allow certain products to be marketed. And let me also add that increasingly today, products are put on the market with restrictions. Restrictions with perhaps only to be prescribed in the hospital, or only prescribed by specialists. And also now they're talking about a preliminary agreement. Maybe you could talk about the restrictions, and then I'll ask you all perhaps to, it's very Franco-French, and I'll ask Eric, and then I'll ask you all for a general comment. Yes, indeed, certain molecules that are quite innovative and are reserved for prescription in the hospital only. Now, there are reasons for this. Examples such as oncology. These are very targeted therapies, quite innovative, and reserved indeed for only hospital usage with strict supervision. And you also were talking about waivers and exceptions to the rule. Now, in the French system, yes, there are some exceptions that are foreseen, such as temporary authorizations. These are systems that plan for early access while awaiting the market authorization. Now, we can maybe debate the number of systems that allow us to achieve what we call these ATUs, temporary authorizations. Now, in terms of the financing methods, and now I'm coming back to this notion of target, this morning we discussed in depth the notion of targeted approaches, and I'm completely convinced that this is one of the solutions. And I think that an approach that would take into account the benefits, the value created for, in other words, change rationales, move away from a discussion of price for the industrialist and cost for society, and move towards the idea of a created value. And this is similar to what you were saying, Madam. And I think the value created for the patient remains fundamental. This value can be assessed in clinical trials, but it can also be assessed with other data. And this is similar to this notion of outcome, this notion of financing that would be much more personalized, I think sincerely will be a solution that will allow better management. Because it's true that certain drugs can have a benefit or an impact on patients which are differentiated. We might imagine that today a drug may exist that generates benefits for certain patients, but which depend on the indication, which depend on the population, patient population, and benefits that are different depending on the tumor, if we're talking about oncology. And today, the system of financing that we have is a system which I would say, if you look at, we're looking at price per milligram, price per bottle, but it doesn't take into account the whole chain of value creation. Now, this created value and personalized financing, this is going towards this idea of the preliminary agreement. There are a lot of criticism, for example, recently of anti-cholesterol drugs. It has been decided that there might be a preliminary agreement before new prescriptions. Yes, this problem of the preliminary agreement or prior agreement is an administrative question. We just described all these problems of lead times and choices. This is an administrative answer to a true issue, which is a medical and economic issue, which is the question of budgetary constraints, which will oblige us in tomorrow's medicine to make choices. And no one can deny this issue of having to make choices. We will have to make choices between therapeutic strategies. And here again, I think that the deficiency value, in other words, this comparison between the efficacy but at the right price or at the best price, is a future perspective that we cannot deny. I regret that in France we've taken this issue in a very administrative way, whereas I think we could have had some very strong proposals through agreements, through consensuses with all of the partners. And I have a term that I like, that I often use, which is the term of the right usage, which is a kind of a mix between the right place in the therapeutic strategy and the proper usage. This is a key, perhaps, to intelligently use a drug, intelligently from the medical and economic standpoint. This is what we should have implemented, but in a much broader way, in a much more medical way than administrative only. Now, how would you like to react to this discussion, and maybe placing yourself in the European context or what is happening in other countries? Well, what I've just heard at this table, these difficulties are always linked, or often linked, to administrative procedures. When you're evoking the complexity of a system, previously I was trying to evoke the linearity of decision-making processes. No administrative process, when you add steps, often they can be simplified. You see there are new commissions, new phases. They're always created in a very good spirit, with a good purpose. But it creates what we say in French, a millefeuille with 1,000 layers. Recently, in France, they had the CES system. When you read it, there are no objections to make. It seems important to have an economic assessment and to have elements of use. But that's this information which has been developed, is it actually used in every decision-making forum? Or do people say, no, I have my own decision-making power and I have a different focus? And I think this creates tensions that are incomprehensible to citizens. Sometimes we need to make these innovations available to patients, and it's all very well to present these to the public to promote into innovation, but promoting innovation means taking this innovation and really bringing it to the end final consumer, whether it's a patient or a citizen. And I must say, we talked about vaccines. This is even worse because we have vaccines that are linked to programs. And here in the classic passage in France, I know you have technical vaccination committees with public health authorities that have another opinion. And sometimes this can generate an element of conflict with the different decision-making bodies. And at the end, we discuss the conflicts between the different bodies, and we no longer discuss the actual product and the impact that it can really have on a population. And I think this is truly a problem. People are actually no longer discussing the real benefits of a product. I think you'd like to react to that? And then, Eva, I'll ask you your opinion on restriction to access. Yes, I wanted to react to that because I think, indeed, we are at a turning point. The turning point that you've just described is that not only there are innovations, but on the other hand, we cannot deny that we are in an economic context that is difficult. And the challenge is to make these innovations accessible to the patient and at an acceptable cost for the authorities. And you were emphasizing earlier this notion of responsibility. I think there are some extremely interesting things to say. The cancer plan number 3, there's an objective number 17 in this plan, which was to adapt financing modes of today to the challenges of oncology. This is one example that shows that there's a real raised awareness and people want to move forward. And I think that's an excellent sign. Now, it's up to us, all of the players, to assume our own responsibilities. And I think that the pharmaceutical companies have a role to play also and to contribute to the search for solutions. Thank you. Yves, with respect to this discussion, we said that there were a certain number of processes that are being implemented that complicate market availability of drugs, but that might also complicate patients' lives. Do you think that this will generate problems, or do you think that in the end patients will find a solution in the middle of this obstacle course to find the products that they need, even if they're not in a big city like Paris or another major French city? Well, indeed, these administrative restrictions will complexify patients' access, but I think this meets the need that we had poor prescriptions. And so when the messages have been repeated and recommendations have been made over and over and they're not followed, then I imagine that it is necessary to act. And the authorities had to act. And what's too bad is it is the patients that will be penalized because this administrative complexity will be something that they suffer from. It's true that the economic challenges, the economic do play a role, but they're not just economic challenges, they're also qualitative. So there are a certain number of justifications linked to the fact that these products are difficult to handle, complex products with side effects, adverse effects. So maybe you'd like to react to this point and to the need to optimize the use of products, and that this access could support this optimization. Well, I have the impression that we all agree here around the table. If the issue is to use, again, the drug under the right conditions for use and in the right place, it's efficacious place when there's a choice between several strategies. I think today there's a very broad consensus to move towards this objective. But the problem of this prior agreement or preliminary agreement or approval this may slow things down. There may be a lot of discussions based on arguments and criteria that may cause a lot of people to lose time. I think we're kind of going around in circles when we talk about the price of drugs in this discussion. I think it is a true issue. That is the question that I didn't ask yet, and I was about to ask it. And we did see an illustration in the little video and in the cartoon, which is indeed that the price of a drug and the level of that price. I think everyone around this table, we were struck by the fact that in recent years, and there was not only the recent example for hepatitis C, but there has been an increase in the price of drugs for certain anti-cancer drugs that are quite targeted, etc. And this is a huge issue, and I think that we do need to address this question here. And to give some perspective, and how can we situate ourselves with respect to the fact that the price of certain drugs is incredibly high. We see certain older drugs whose price is going down, but we see new drugs arriving that are costing 1,000 euros and more. So I'd like you all to answer. I think this question is in the background of almost every discussion today, increasingly, and we shouldn't ignore the question. We should indeed confront it head on altogether. I think there are two levels of questions here. There's a lot of irrationality. It does question the rationality of the prices, and I think that here the pharmaceutical industry must explain how they construct their prices. I'm always so surprised to see how the media explain the prices of drugs just like the price of a loaf of bread in a very vertical. So they say, as though it were the price of the water and the flour and the baker's hourly wages. You have to remember that drugs cannot be compared. It's a huge result of enormous R&D, and we need to continue. People need to continue to be able to invest, and that is the business model of the pharmaceutical industry. So we have to respond to the rationality of our prices. Secondly, there's a lot of anxiety linked to the sustainability of the system, and here we have a true need for objectivization at this price level for the target populations of the drugs in question. Are we jeopardizing the sustainability of the system? I do not know, and I don't think anyone knows, because no one has ever modeled truly the pharmacopoeia of the years 2015 or 2020. There will certainly be much more expensive drugs, biological drugs, cellular therapy, aggregates of several treatments that will arrive together on the market, but for smaller target populations, and in parallel, there will be others. So I think we need to really objectivize the situation and analyze it. And there's a third topic that we all should address together. I think, nevertheless, once all of this has been said, we need to recognize that we're probably sliding away from a system that was absolutely obsessed, and here I'm speaking as an industrialist, by the value-based pricing. The industrialist says the right price is the price of the value of my drug. And he's not wrong. That should be the core of the demonstration. But today, that's no longer sufficient. And I think we need to go away from value-based pricing to fair pricing. And what I would add to these considerations around value in the notion of fair pricing is also the notion of the economic imperatives of both sides. For the industrialists, it is my capacity to get a return on investment and to continue to invest, but we also have to look at the payer's side, and there's the question of sustainability and the budgetary impact. So the problem is the gap and the difference that may exist between the value-based pricing, and I think everyone in this room is aware of that and accepts the principle of that you need a return on investment. That is not where the question lies, but the question is, what is the level of the return on investment? And is that return on investment used properly, or is it used for other more capitalistic purposes, which is normal? So that is a huge question, I think. Andrea? Well, this is very interesting because speaking about the value of a drug is quite it's a real commitment. It's quite engaging. At the end of the tunnel, there is a budget and a price that we have to set. And this gives people a stomachache or a headache sometimes in all of these conversations. But the problem is, how do we measure this? And as the English say, against what? Because it's not a perceived value. Let me use another English word. Value is in the eyes of the beholder, just like beauty. Beauty, everyone can see beauty. Beauty is in the eyes of the beholder. And the value of a drug will depend on the situation. And at Vaccine Europe, this association of vaccine producers in Europe, we did a very interesting study. We took the population of Holland, over 50 years old. We calculated if we vaccinated all of them, the cost to vaccinate the entire population over 50 years old would be 100 million euros, more or less. And so it would be for the flu, the boosters, pneumonia, and shingles. These are vaccines available today. And we measured the fiscal impact, and we were able to prove that they actually saved money. They saved 500 million euros. What do we mean by a fiscal gain? Well, that means these people don't go to the doctor. They go less to the hospital. They don't have sick leave. So it's a global impact. And so that allowed us to say €1 invested saved 4 additional euros. So that is really interesting from the standpoint of the economic model, and it's absolutely impossible to sell. We can't sell the idea in any country, including France, because this doesn't exist. It's a value that people haven't analyzed because the value is in the budgetary envelope of the pharmaceutical products. And so when there's an innovation that can have a huge impact from a societal standpoint, for example, there are demographic challenges with all of these elderly people arriving and increasing, we can find solutions. But in the end, this is translated in the decisional processes. And I think that's the limits of where we are. We talk a lot about price. We talk a lot about value. We look at them as though they were antagonistic. But indeed, we need to put them in the context. It's a value for what? And I don't use the word society in the broad sense. I'm talking about the real economic and fiscal impact for a society that frees up other resources that we can invest elsewhere in other therapies, perhaps, that cost a lot more money. Yes, but we need to try to rationalize. Earlier, you were invoking beauty. It's great if we all have our own vision of beauty, but we can't afford to pay for all these differences. So we do have to try to be as objective as possible. Now I'd like to ask Frédéric if he would tell us in his vision how we can rationalize as best possible. How can we succeed in designing a system that is as objective as possible and still trying to go towards a consensus for the benefit of the patients? We always oppose industry and the payers, the health authorities, but are they not actually all going in the same direction? And isn't there an interest for the industrialists to place on the market the most innovative, important products that actually improve medical services and that are paid at the fair price? And to do this, this needs to be measured.
I think that the main essential point is that we have to contribute together. Industrialists won't do it on their own, and the authorities, they're going to need drug companies, health professionals to be involved too. So each has a role to play. Then let's come back to the definition of value itself. So a value that we know is the clinical benefit. There's another value that is a little bit more difficult to measure, and that is the quality of the life of the patient. And again, that is a fundamental value. And then there are other types of value that are not taken into account today. For example, the value for society. A patient who recovers health and lives a better life is going to be more alert, he's going to be able to produce wealth, and that is value for the patient, and that has to be taken into account too. So this loops back to what was said this morning and the notion of outcome and the notion of measuring that outcome, whatever the outcome. So I'm convinced that one of the solutions is going to be, accessing data. Today, we have a system in France that is extremely methodical. We've got clinical trials. Now we need to find out how, in real life, we can measure the benefits produced from clinical trials. This is a fundamental point, and I'm sure that it will take us through to very different differentiating modes. We were talking about the different systems. We need to take into account the patient benefits, the values created for patients that may be different from one population of patients to another. In oncology, we have examples of molecules that are highly innovative, but which have an impact on patients that's going to be different. So the benefits created, the values created for patients are different, therefore. So we need to take this into account even in financing modes. This is something that we need to think about. And that's how we can maintain innovation in France, if we continue to think about these things. So the evaluation of value in real life, this is something that we've been talking about for a while now. But basically, we haven't seen very much demonstrated in this field. Do you think we can assess, we can evaluate? Is this one of the solutions that we need to find for the future? We need to find means to have these evaluations, these assessments and criteria so that we can move towards the consensus that I mentioned. Eric? Yes, well, from a purely economic point of view, just to come back to what our friend was saying there are some measurable savings to be made in the system. When you introduce medication that reduces the frequency of hospitalization or reduces the different complications, cirrhosis, for example. That's an excellent example, transplant versus dialysis. The problem is that there are 2 points of view. First of all, there's the time-based point of view. Objectives always depend on the input cost of the medication. We can talk about cirrhosis. We're talking about €10 savings. How do we recover the savings made when, in fact, the initial investment is considerable? So there's a real question of timing. We need to widen our focus. We need to understand that that's important. We need to understand that we're governed under the annual law of the PLFSS. In other words, we look at things from one year to the next. So this is something that we need to think about better. We've got the envelope as well. People with whom you talk about the price of medication, well, the people are the UPS. The UPS does a good job, but it talks about its own envelope. In other words, they only report on the quantity of price reductions generated by that authority. And the impact of the medication introduced in terms of hospital savings, that's not something that this authority takes into account. So that's from an economic point of view. From the point of view of real life, I think we all agree that there's a great perspective with all of the assessment institutes available. We need to take out a wager. We need to look at the real-life data. We need to look at how to make these two appointments match. We need to be able to systematize things and in a faster manner. Thank you. But this brings us to the end of the panel discussion. Well, we've got 5 minutes. I'm going to ask Yves to talk about price questions, and then you'll each have 1 minute just to say a few concluding words. Thank you. I think that what was said about the price assessments and the interests that are sometimes diverging between the state, the pharmaceutical companies, that's all very interesting. But let's just focus on the medication that I mentioned. It was estimated that this medication would extend the survival of transplants by 2 years. The calculation was carried out based on the given price, the price that hadn't yet been negotiated. So these, we would have savings, health savings for the health and safety department. So €20,000 a year. That's quite significant. This cost does not take into account all of the other advantages that you might imagine in terms of quality of life, less sick leave, less cardiovascular and metabolic problems. So people would be able to stay at work longer. There would be less weight on the social security system. So I think we need to think about that on a more long-term basis. You know, evaluations of access to medication. This is something that hasn't been taken into account for the product that I mentioned. Yes, I think we need to reach consensus about this 2-year period. It's a subject that is fairly complicated, I agree. One word. So let's start with Andrea. 1 minute each of you, please. So one word for me, investment in health. I think at the end of the day, we can talk for hours about these different things. We can talk about different populations. We can talk about how to work with pharmacies and how to heal people, how to make life better and reduce the health budget. We can talk about that for hours, but there's no real logic in the private area. If you have to close a factory, the first year it's going to cost you a lot more money in terms of the benefits that you have the next years. The needs in terms of investing in health, and I'm talking about intelligent investments, you have to calculate these. But if we just want to save exclusively and have our cake and eat it, well, and of course you have to think about the product and whether it meets what we imagined it would do. So at the end of the tunnel, there's always light. We mustn't forget that. But then you've got to be careful that there's no train coming the other way as well. I think that just to sum up, we've got a great opportunity here. We have been working in the pharmaceutical area, and we've been seeing great changes in terms of therapeutic innovations, but also in terms of our own job, our own profession. And I think that the focus of drug companies was on discovering new innovations. So I'd like to reassure everybody, it's still the focus, but I think also we've got to take on board the notion of making these innovations accessible to patients and acceptable for authorities. And that's our responsibility. So what I can say to finish is that we need a collaborative approach with all of the stakeholders involved. This is something that's essential if we want to get the system to change, if we want to change the financing method. And 3 or 4 words that I will take away with me. Well, the importance of data in real life. There's also the notice of targeted approach. And then your example, madam, we can see that the value created by a drug has to be broader than what we consider today. It has to take into account other things. Yes, so we've all said that we're seeing a real bad news, the return of therapeutic innovation. I'm saying this very ironically, of course. But anyway, this is going to make us, it's going to force us to rethink our system, the way medication becomes accessible on the market. So we have to have the right use and the right price. Yes, thank you very much. Now, I would like to say thank you to this lady for coming. Without her, the debate would have been quite different. So I'll hand back over to Guy now. Thank you.